Hello, Insta family. It's Dr. T here, coming to you on a blustery Wednesday night. I hope you guys are doing really well. I don't know if you can hear, but we have maths homework going on in the background. There is some serious 2 times table happening. So I'm going to have to talk over the top of it. Hope you guys are good. It's been a little while, but we're back for our rapid fire Q&A. Quick update on me. Cycle 3 of chemotherapy is down. I am officially halfway. I think that's all I've got to say about chemo. It hasn't been a fun journey. But it's good. It's good. I'm halfway down. So that's great. And once again, thank you for all the love and support that I have received from every single one of you guys. It's been simply amazing. And it's an incredible feeling. It's a humbling feeling, actually, when people just smother you with so much love and care. So thank you to all of you. Now, rapid fire Q&A to those of you who have joined. The usual guidelines. So you're free and welcome to drop any questions you have into the comments. Try and make them fairly succinct. Don't need your whole life story. Certainly won't be able to solve your medical condition tonight. Anything that you question, I'll try and make as generic as possible and try and keep it fairly clean. I've got a couple of questions that have come to me via DM. So Penelope asked a question about testing for chromosomal abnormalities. So you all may or may not know that we all have 22 pairs of chromosomes, 1 to 22, and then we have an X and an X or an X and a Y, most of us. And so sometimes babies can be born or have conditions where they have too many or not enough of any one of the chromosomes. So the most common one that we all know about is something called trisomy 21, or more commonly known as Down syndrome. There are other conditions as well, which can be born alive and quite severely affected. Trisomy 13, trisomy 18 are other conditions. And it can be really devastating for families. And we can actually test embryos for trisomy, or if it's, so that trisomy is when they've got too many, say, of 3 copies of a chromosome. So trisomy 21 is 3 copies of chromosome 21. Or it can be monosomy, which is only 1 copy. I think they just got the multiplication right. So we can actually test embryos using IVF. We can do pre-implantation genetic testing of embryos to confirm that they have all the right numbers of chromosomes, or if they have too many or not enough. And we call this PGT, pre-implantation genetic testing. So the process for PGT is you create embryos using IVF, and you grow them all the way out to what we call blastocyst, which is usually about day 5 or day 6. And then we take somewhere between 5 and 10 cells out of that embryo, and then that embryo is frozen, and those cells are sent to a genetics lab, and they can amplify those cells, so grow them up from just those 5 to 10 cells to hundreds of cells. And then they can do genetic analysis on them to tell us certain things. So they can tell us if there is an abnormal number of chromosomes. We call that aneuploidy. So it's called PGT-A. A stands for aneuploidy. It can also tell us if there is a specific gene mutation that has been identified, say, in the parent, or even in another sibling or another family member. So that's called PGT-M. So M stands for mutation. And the other type of genetic testing is where you can get a crossing over of part of chromosomes. We call that a translocation, and it's often responsible for multiple miscarriages or a child with a syndrome. and that's called PGT-SR, standing for structural rearrangement. So we can use sampling of embryos and genetic testing to help families overcome the burden of potential illness in a future child, and deselect those embryos, so not utilize those embryos. Fascinatingly, taking out those 5 to 10 cells has in research not been shown to do any significant harm to those embryos moving forward. So it's an amazing technique that we have at our fingertips to help families in any one of those 3 situations. So Penelope, I hope that has helped you in understanding how to potentially avoid a child with a trisomy. Let me see if anyone else has dropped anything, because I do have one other question that was sent through to me. Oh, dog's barking. No, you guys are just listening with bated breath. Gosh, okay. So this is a bit of a multi-step question. Somebody has asked, what are the statistics of getting pregnant each cycle, and how does that change with just not monitoring? So let me start again. What are the statistics of getting pregnant each cycle, just, throwing caution to the wind? What then is changed, or how the statistics changed if you intervene in some way, whether you monitor or whether you might do something like intrauterine insemination of a sperm sample, or even IVF. Okay, so let me see if I can break this down. Fecundity, it's a funny word, is the ability or the chance of falling pregnant each cycle, or each month if you've got a regular cycle. And we put that across our population at around about 20%. So you have a 1 in 5 chance of getting pregnant each cycle across your reproductive years, assuming everything is kind of normal. However, that is going to be affected by age and time. And there was a nice study done, I think it was about 10 years ago now, actually it might have even been longer, where they looked at populations who were trying to conceive, and they looked at their age groups, so 25, 30, 35, 40, and they looked at how long they had been trying to conceive. And what they really nicely showed is that the longer you have been trying to conceive, the lower your chance of conceiving each month. So let's say you'd been trying to conceive for 6 months and your previous rate of trying had been 20%, it now drops to 15%. And if it has been 12 months, then it drops down below 5%, and 18 months drops down to 1%. They also showed that the older the age group was, their initial chances of trying to conceive were less. So they weren't 20%. So a 35-year-old trying to conceive, their chance of conceiving is not 20%. It's probably more likely in the order of 15%. Dog. And their chances declined with time as it moved on. Right up to a 40-year-old, their chance of trying to conceive might be 1 to 5%, right? So time and age matters when we're talking about your ability to conceive each month. It's not 20% across the board, right? You met your Mr. Wonderful. It's like, okay, let's go, buddy. Our chance next month is 20%. Depends on your age and also how long you've been trying to conceive. So then we go, all right, what if we are simply monitoring you? So we are checking your hormones, maybe doing an ultrasound. We're seeing that you're starting to surge and we're saying time intercourse. So does that kind of intervention help? It really only helps if someone has not really understood their cycle. We've all seen, as a fertility specialist, we've all seen patients where we've instituted a tracking cycle, assessment cycle, where we do some blood tests and we observe ovulation, LH surge, and we say, go and have timed intercourse and they conceive. It happens. But really, it doesn't increase your background chance of trying to conceive. It was just your month. Whether you are timing intercourse around that LH surge or you are having sex 3 times a week, so fairly regularly, your chance of spontaneously conceiving is probably about the same, right? So sometimes I think we get a little caught up in this. It must be, 12 hours before and the sperm can only hang around a certain amount of time. The reality is it's probably not that precise. What about if we intervene and we do something like intrauterine insemination, where we're tracking your cycle, we see the LH surge, we take a sample of sperm, we wash it up, we get rid of the immotile ones and we put them inside the womb a little closer and a little more concentrated. Generally speaking, IUI will probably amplify your background chance by about double. So if your background chance was 5%, we've probably bumped you up to about 10%. Still not fab, is it? So IUI as a treatment is not really that successful, although we all know plenty of people that have conceived on IUI. But across the board, I would say IUI, it probably has about a 15% chance of success each month. And that's why a lot of centres don't bother offering IUI to patients, because the success rates for you guys, given what you have to do to achieve that, so you've got to have blood tests, you've got to come in for ultrasounds, your partner's got to provide a sperm sample, it's costly from a time, effort, and money point of view. The results are not that great. But some people would like to do IUI. I personally don't persist with IUI beyond 3 to 4 cycles because success rates really plateau and there's something else going on if you've not conceived. And then, of course, the next step up is IVF. And we know that success rates with IVF are far greater than IUI and far greater than just timing an assessment cycle. But of course, there's lots of treatment burden that comes with that. So to the person who asked that question, I hope that's helpful. I actually hope that's helpful for a lot of people. Where does ovulation induction fit in that? Ovulation induction is a treatment for people who don't ovulate or ovulate irregularly. So if you have a regular cycle and you've proven ovulation induction is not the right treatment for you. Don't bang that drum. Don't go down that pathway. All right. Anyone else? There must be some questions. Come on, guys. Usually you're throwing them at me. No worries, Penny. My pleasure. Any other questions? Someone's got to have a question. Is someone busily tapping away their question? I hope... let's see, anything coming through. Can you ask a question? Go for it. Whether I can answer it or not. Yeah, go for it. Question about ovulation and endo. Ooh, this would be an interesting one. Ovulation and endo. Does endo affect ovulation? Is that what you might be asking? Anyway, see if you can clarify it a bit for me so I can give you a half-decent answer. What else can I share with you guys? What has been a feature of my week? Getting out of bed. That's a big feature of my week. Oh dear. I have learned how important sleep is when you don't get enough of it. It's amazing. Actually, I will share something with those of you who may be menopausal or perimenopausal, how important sleep is for managing hot flushes. You will find that if you are sleep deprived, your hot flushes will worsen, and then your hot flushes will worsen your sleep deprivation. So the two are intimately linked, and that is why sleep is a key management strategy for the perimenopausal. Okay, we've got some questions. Gardens and Graves. Confirmed stage 3 endo, 6 months post-excision, bleeding after sex during ovulation, then a massive endo flare. Oh gosh. Okay, all right. The first thing I want to say is postcoital bleeding is never normal. So that should always be investigated. You should always see a gynecologist and it is recommended, or certainly the Australian guidelines are persistent post-coital bleeding should be assessed using colposcopy, right? So the cervix absolutely needs to be assessed. So that's the first thing. Massive endo flare-up. Well, you could be having bleeding because of that, but absolutely you need to rule out any cervical abnormalities. And does the ovulation flare the endo? Well, think about what induces progression of endometriosis, and that is estrogen. When you are at peak ovulation, your estrogen is at its peak. So you are in an inflamed environment when you are having natural cycles that aren't suppressed, and your estrogen is high. It is going to be feeding that really abnormally placed lining. We also know the endometrium of women with endometriosis is not normal. And so it is not unusual to see abnormal bleeding patterns, particularly in the luteal phase of a cycle with a woman with endometriosis. So premenstrual spotting is a characteristic that we will often see to signify endo. I don't know what's going on with that dog. But anyway, so hopefully that's helpful, but I would strongly recommend you go see a gynecologist. Thoughts on sex the night before day 5 frozen embryo transfer? Hell no. No. Please don't have sexual intercourse in your frozen embryo transfer cycle. You should have been instructed this by your gynecologist or your fertility specialist, because sneaky sperm can go places, and particularly if it's a natural cycle FET or low dose stimulation, you're going to be releasing an egg. And there could be dire consequences. And let me tell you, it has happened. What would be the purpose? I know that there is research out there around the immunological value of semen in reducing things like preeclampsia and sort of implantation issues. However, that's always given with the caveat that let's not use the semen that also contains sperm. So we are yet to see any commercially produced agent, but I'm sure that there are people working in this space. But certainly in my practice, it's a big no-no, not in a frozen embryo transfer. Jess Cook, you did ask that question. I forgot to write that one down. Does the pituitary gland go to sleep? I think you termed it hibernation, and I kind of like that term. I've never heard that term applied to the pituitary gland before, but I love it because it describes quite eloquently what hypothalamic suppression of pituitary function is. It's kind of a survival mechanism. So if your pituitary has gone to sleep or gone into hibernation, it is because the hypothalamus is not producing GnRH in the right amplitude or frequency because of neurotransmitters and chemicals that are saying to the hypothalamus, shut down that HPO axis, shut down the pituitary and the ovulation, and in the ovaries, because now is not the time to conceive. So we see this sort of pituitary going to sleep situation when women lose significant amounts of body fat, perform high intensity activity. They may be taking medications such as antipsychotics, which can impact on hypothalamic function. What other things? Opioid, analgesia, or sort of illicit opioid usage can do it. So there's lots of different situations, and they can be cumulative. So we know that, for example, in eating disordered populations, even though young women may regain the weight that they have lost, even to 2 kilograms beyond the point at which they lost their periods previously, only about 50% of them will the hypothalamus hypothalamus and pituitary axis actually kick back in. And that's because there's a certain element of the psychology, so the anxiety and the anxiety hormones, that unless that part of the axis is dealt with, then the situation is not fixed. So how can you resurrect a sleeping pituitary? Well, do the opposite of the behaviours that might have led to it in the first place. So, check your exercise. Are you perhaps over-exercising? Check your body fat levels. Look at any medications or lifestyle factors. Make sure your nutrition is sort of optimal, calories particularly. Psychological therapy. So we know that CBT has been used to help. So they're just some of the things. And sometimes in some young females, it never really goes back to normal. So it is a difficult one, but functional hypothalamic suppression or functional hypothalamic amenorrhea is a condition I'm very interested in because it does have implications for reproduction and also for pregnancy. Great question. Love it. Hibernating pituitary. I'll use that again. Is there anything we can do to increase the potential for embryo implanting? Yeah, don't smoke. That's a good one. In all truthfulness, even with chromosomally normal embryos, we can't get much higher than sort of a 50% chance of embryo. There are some places in the world that sort of quote 60 to 70% pregnancy rates, but that's often when they're putting multiple embryos in. But in truth, we probably can't get much higher than 50%, thereabouts, plus or minus a bit. So what other things can you do to improve implantation? So consider lifestyle factors. So again, you can look at diet. The information around this is fairly loose. So I kind of talk around a Mediterranean style diet because all of the sort of longitudinal studies around fertility have kind of lent towards that Mediterranean style diet. Perhaps there are some microbiome things, but that research is kind of still evolving. Definitely managing endometriosis, so either surgically or medically. I won't go into the depths of that. What else can you do? Vitamin D levels are thought to be important. Again, still kind of emerging levels of evidence on that one. Don't smoke. What else can you guys do to improve implantation? I think they're the big ones. And then, live the moderate lifestyle. So don't be over-exercising. Don't be under-exercising. Watch your body weight. Like, a lot of this is stuff that if you're asking this type of question, you're probably already quite aware of and optimizing anyway. Everything else requires some sort of intervention. So it might be managing fibroids or polyps. It might be managing endometriosis, adenomyosis. It might be investigating endometrial receptivity issues, looking at thin endometrium, scar tissue, and so on, and so on, and so on. So I'm hoping that is a very generic answer to your probably quite specific question. Okay, Life of Brit, good to see you back. Can you explain step by step an average IVF cycle? Oh my goodness. Okay. I'm going to do this. Let's see if I can do this in literally 5 minutes. An average IVF cycle. So the purpose of IVF is to get multiple eggs collected. So every month you are producing a number of eggs, a cohort of eggs, and normally one ovulates off and the others, they just die. So in an IVF cycle, what we're trying to do is recruit an optimal amount of those eggs that are being recruited in that cohort. And ideally we aim for somewhere between 8 and 12 to 15 eggs. That's our goal, because that's that safety efficacy balance. So how do we do that? We give you the same hormone that your brain produces, FSH, but a recombinant version in an injection. So you would ring up on day 1 of your cycle. You've already been set up with all your medication, and that's when we press go. So you're giving yourself a daily injection of this FSH, but at much higher doses than you would normally be seeing, because we don't just want to recruit the one follicle for ovulation, we want to recruit them all. And they all start at about 0.5 centimetre, and we want to aim for about 2 centimetres per follicle. So yeah, your ovaries start like that, they end up like that. Are you going to feel symptomatic? Yes, you are absolutely going to feel symptomatic. I don't know of a person who has been through IVF that hasn't felt some sort of symptom: bloating, distension, moodiness, all of that in some degree. So you're having these daily injections. Every couple of days, you're going to have a blood test and or an ultrasound. We're going to be monitoring your rise in hormones and also the growth of these follicles. Around about 2 weeks in, when we're happy with the follicle growth, we will then give you another injection, and that's called a trigger. And that trigger injection, that's like your LH surge. So it causes the eggs to mature in the follicles, and then 2 days later, you get an egg collection, which is essentially a surgical procedure. Those eggs are then taken out and they are inseminated with partner, donor, whoever's sperm, and then we create embryos. And then we grow those embryos ideally out to day 5 or blastocyst stage, and then we take them out of the incubator and we transfer one in most situations back, and then you do a pregnancy test 2 weeks later. So it all happens within a cycle. I forgot there is often another injection that happens, but I won't complicate it, about a week in. So that's kind of like an average IVF cycle. So it requires your time, it requires your commitment. I think IVF is burdensome socially, emotionally, physically, spiritually, financially. It is a burdensome process. So you have to be ready. You have to dive right in and commit, because it's a big process. So hopefully that was helpful. Whew, I don't know, did I do that in 5 minutes? I think I did. Fantastic. All right, guys, I'm going to wrap it up. There were some really great questions today. Thank you. And thank you so much, everyone, for the love and support. I've really, really appreciated it. I am day 8 post cycle 3. So I've now got 2 weeks reprieve till cycle 4, then cycle 5, then cycle 6, and then I'm done. So Independence Day, July 4, Independence Day. It's my last cycle. So we're going to have a party, and I hope you all come. See you next week.